Hello and good evening. This is Manos Brilakis from Minneapolis Heart, and it's my great pleasure to welcome you to today's webinar, Cases Over Cocktails for CHIP, which emphasizes today how to manage lesions with coronary calcium. I'm delighted to have with me two amazing presenters. One is Mike Megali from Henry Ford. Welcome, Mike. And the second one is Lindsey Cilia, who is actually just joining us to the webinar right now, who is the Chief CTO Fellow at Mass General Brigham and Women's. So welcome again, Lindsey, as well. And I think you're still muted a little bit. Maybe you just unmute.
Hello. Sorry about that. I had some connection issues.
No, perfect. Delighted to see you on board. And I guess, Mike, should we have the ladies go first? Who's going to go first?
Lindsey can go first. Yeah, ladies first. That's a good idea.
Oh, perfect. Okay. Can you hear me okay?
Yes, perfect.
All right. I'm going to try to share my screen here. Right here. So I clicked share screen. Can you guys see my screen?
Not yet.
Let's see here. Hang on. So I click share screen and it says all panelists. I'm going to exit out of this and hit share screen again. All right. How about now?
Perfect. Yeah, there you go. That's perfect. Thank you.
Perfect. All right. So just to outline my presentation, I'll go through two atherectomy cases, one CSI, one Rota. I'll define some severe calcium by fluoroscopy, OCT, and IVUS. I'll explain a calcium decision-making flowchart and some calcification complications and outcomes, atherectomy complications, perforation management flowchart, and leave some time for questions and discussion. So case one, we have an 80-year-old male, history of hypertension, hyperlipidemia, coronary disease, prior PTCA to the LAD in 1994, moderate AS, HFpEF, who came to MGH with acute decompensated heart failure. Echo showed an EF of 72% with an aortic valve area of 1. Referred for right heart cath and cores at that time. Medications are listed for your review. Allergies, no known allergies, and a former smoker and a social drinker. Right heart cath showed normal filling pressures with an RA of 3, a wedge of 10, and an output index of 5.8 and 3.0 by TDs. Cardiac cath, I'll show the images in a couple seconds here, mostly focusing on the LAD, which showed diffuse calcification and 2 sequential severely calcified eccentric lesions, 80% then 70%. The RCI also had notable disease, but IFR was 0.95. So here again, on the left-hand side, you can see the severely calcified prox LAD and mid LAD disease. Not much left main disease, luminal disease in the circ. And then on the right, you can see non-obstructive disease on the right that again was IFR 0.95.
And Lindsey, just a quick question. The patient did have angina or dyspnea. What was his main presenting symptom?
Acute decompensated heart failure.
Okay, but no angina.
No angina.
Okay.
So in terms of for PCI, we opted to go left radial. We used a 6 French system. We used a CLS 3.5. To cross the lesion, we used a Xi'an black and then a fine cross. And then we swapped out for Viper wire. We decided to go with CSI for this case. Our prox LAD, we did orbital atherectomy at 80K antegrade, and then 120K anti and retro, multiple runs. And then in the mid LAD, we did multiple runs of 80K and 120K as well. After that, we used our fine cross to swap out for a wiggle wire to maximize our support in the case. We focused on the middle AD. We did a balloon angioplasty with a 2.512 NC and a 3.012 NC. And then we placed a 2.518 Zions drug-eluting stent to the mid segment. And then we post-dilated that to 3.0 and 3.5 proximally. IVUS guided.
I'm sorry, maybe you just go back one slide and maybe have a little discussion with Michael. So Michael, you're seeing this lesion and the patient has severe AS. I mean, couple of questions for you. First of all, do you have to do it or you can just leave it alone or do it after the cover? Number one. And number two, given the severe calcium and what the IVUS shows, would you do atherectomy up front or would you try a balloon first?
I think I agree with doing it given the decompensated heart failure and the presentation. Looking at the IVUS and the angiogram, I think some school of thought would be to maybe try an angiosculpt first, but definitely with this amount of calcium, upfront atherectomy would be also reasonable. We had some success with using current balloons and angiosculpts recently with like 270 and 360 degrees calcium. It breaks and everything goes well, but it's of course very reasonable to use atherectomy here, especially orbital.
Okay, I guess you do see it's actually more than 180 degrees of calcium, which is one factor. The calcium, it's hard to tell by IVUS, but looks like it's relatively thick. And the length, it's hard to tell, but it's probably more than 5 millimeters with the criteria by OCT. So, again, very reasonable to do atherectomy up front. And also very reasonable to use the wiggle wire for delivery. Was delivery, Lindsey, was it difficult delivering equipment after the atherectomy?
Yes, it actually was pretty challenging. We were able to eventually do it, but we didn't have to use any angiosculpt or Wolverine balloons, which may have been even more difficult to advance. But luckily, the NC balloons were able to deliver easily, and then we were able to deliver our stents. But I think we would have struggled if we didn't use a supportive wire like a wiggle to complete the case.
Perfect. Thank you.
And then to the Prox LAD, we placed an overlapping stent. We balloon angioplasty with a 2.5 and a 3.5, and then we placed another Xience 3.5/18, post-dilated to 3.5/40 and 4.5. And again, IVUS demonstrated a well-expanded and a post-stent. So the patient did not have any angina during the case, and actually he's getting serial TTEs for his AS management. Moving on to case 2, we have an 80-year-old male, history of hypertension, hyperlipidemia, coronary disease, distal RCA stent placed in 2010 along with a circ stent. He presented to outside hospital initially with chest pain, ruled out for ACS, had an exercise SPECT with inferior ischemia. At that time, he was planned for a diagnostic course plus minus to evaluate his coronaries. Meds are listed, again, former smoker and social drinker. So here are diagnostic Cath images. This patient did have multivessel disease. The D2 here, the diag here, you can see it's an eccentric calcified lesion. I'll go through it was DFR'd positive 0.89. LAD was IFR'd and it was normal. Circ also significant disease here. 80-90% calcified lesion, and then distal RCA proximal to the prior stent had a 90-95 calcified lesion. Given the inferior ischemia on exercise SPECT, the outside hospital opted to intervene on the distal right coronary artery. And so they went left radial. Initially, this attempt at outside hospital was unsuccessful. They crossed with a pro water initially. Multiple balloons were not able to cross at that point, so they tried to add the addition of a guideliner at that point. Again, they were not able to cross multiple balloons. They tried a 1.5 and a 1.0. They tried to wire with a Xi'an blue, which was successful, but they were still not able to pass any balloons. They tried with numerous microcatheters. A turnpike LP didn't cross, a fine cross didn't cross. And they decided to stop the case at that point and transfer to MGH for further management.
And what's interesting here is actually, that was a JR4 guide, right, if I'm not mistaken there.
Correct, yes.
Okay, so that's probably part of the reason they had such difficulty in support of JR is probably very low, especially in the patients with such a complex disease.
Correct. So when they came here, we decided to go femoral. We put 7 French right femoral artery, used an AL1 for our guide for more support. We placed a long 45-centimeter arterial sheath also for additional support. We crossed with a Xi'an wire. We used an MCath to get across the lesion, which we successfully were able to cross. And we swapped out to Rota floppy, and we decided to go with rotational atherectomy here with a 1.5 burr. Multiple passes was very difficult to initially actually break through that calcium. And eventually we were able to, and we opted to swap out to a Grand Slam for additional support as well throughout the case. Oh, I think someone raised their hand. I got a notification. I don't know if we want to stop for questions now or I'll keep going.
I'm sure if there's any question, whatever you prefer, but I think it's okay. It's better to do it now versus then you forget what was going on. But
yeah, perfect. We can stop for questions.
Yeah, so anyone has any questions from the people attending the meeting? No, I cannot see anything on the chat box yet. Okay, I guess I don't see anything, but yeah, I mean, so please, anyone who's attending and wants to answer questions, the simplest way is put them on the chat box, and then we're going to just address them live. So feel free to do that. And I guess maybe Lindsey, in the meantime, you can keep on going on, but it looks like the main thing that make the difference in your case was using the 7 French, so bigger size. You did use an AL1, so better support, and then you used the stiff microcatheter, the MCath. So a combination of factors allowing you to get a root ablation. Is that right?
Correct, exactly. And then since it was pretty calcified and we anticipated probably difficulty advancing equipment and the potential need for cutting balloons at some point, we decided to go with Grand Slam for more support.
Perfect. And Michael, any other thoughts about this? Would you have done anything different? Are you happy the way things evolved?
I mean, maybe the only question that would be raised right now is if in this uncrossable lesion, and I know we kind of did it before, is like, can we use CSI to cross an uncrossable lesion, or we like forward atherectomy with Rota? Rota was very reasonable here, but it's just a thought-provoking question. Would CSI would have worked?
Yeah, actually, there's no published data, but it does work as well. It does essentially work on the, works eccentrically on the side. Now, many people consider rotational atherectomy preferred for uncrossable lesions. Mm-hmm. But I think CSI could work as well on those. The one potential difference here might be that they have tried several things before and didn't work. They also had a temporary pacer, so Orbital might have less chance for causing bradycardia, but they already had to put a temporary pacer. That's less of a consideration over here. And actually, speaking of this, did the patient go bradycardic, had to pace during the atherectomy runs, or?
No, surprisingly not. Did not require pacing. We had that in just in case because we knew we were going to use atherectomy, and so just for backup, we put the temporary pacing in.
Okay, wonderful. Perfect. So yeah, it looks like beautiful result and great modification of the lesion there.
Yeah, so then we ended up ballooning with the TOC. We were able to cross through a TOC with a TOC after atherectomy, and then we ballooned with an NC Pantera Leah 2515. And then again, IVUS did show almost 360 degree of calcification. The prior stent actually was reasonably expanded and patent. We decided that we did want to use before stenting. We wanted to use an angiosculpt, a 3.0. We tried to pass that, and we did have difficulty even with the Grand Slam. So we used a Guidezilla, and with the help of the Guidezilla, advancing it pretty deeply, we were able to deliver the angiosculpt for further plaque modification. He did experience some chest pain during the case, but we were able to successfully deliver Promus Elite 3038 post-dilated to 3.5 with a Leo, IVUS guided with excellent angiographic results at the end.
Perfect. And then I guess you left the circumflex alone since it was mainly inferior and you thought most of it was the right coronary?
Correct. And he's actually still having symptoms. So he's coming back and we're going to stage the diag and the circ. We're going to try the diag first, see how he does with the IFR positive diag lesion, and then stage the circumflex if he's still having symptoms after that.
Wonderful, perfect. Yeah, another great case. Again, the basics, good guide support, large guide catheters, guide extensions, supportive wires like the Grand Slam, good modification of the plaque. I mean, all these elements to get a nice final result. So very, very well done.
So just some teaching points. We've already discussed a lot of these things, just defining calcium by angiographic, severe radiopacities seen affecting both sides of the arterial lumen. By IVUS, we spoke about these criteria, 270 to 360 degrees, length of greater than 5 millimeters. Again, by OCT, angle greater than 180, max thickness of greater than 0.5 millimeters, and then a length greater than 5. Again, maximizing the support. We spoke about all these. A lot of these are translated from CTO techniques. So consider femoral access when able, 7 or 8 French guide when possible, longer sheaths, 45 centimeters, which we do in a lot of our femoral cases now. If there's any arterial tortuosity and aortic tortuosity, supportive guides like an AL that we use in our RCA or EBUs for left coronary, guideliner trap liners, supportive microcatheters, stiff ones such as the MCath that we used, and supportive wires, Grand Slam and Wiggles. So I found this chart really helpful in terms of coronary calcification flow chart. It goes through a lot of the things, again, that we discussed. So if we see moderate to severe coronary calcium by fluoro or inadequate balloon expansion, go to imaging. We spoke about the criteria for IVUS and OCT imaging. And if you meet those criteria, move on to mechanical atherectomy or laser atherectomy or lithotripsy. If it doesn't meet that criteria, try cutting balloons or NC balloons. If that doesn't yield, again, move to atherectomy. But hopefully at the end, you'll be able to stent and optimize your stent. Some complications that I did just want to touch on, and also 2 quick examples of some complications that we experienced. You can have, if you don't modify your calcium dissect, you can have inadequate expansion of your stent, leading to ISR and subacute stent thrombosis. And also you can have dissection during your balloon angioplasty and difficulty with complete dilation and difficulty delivering equipment such as your cutting balloons or stents. So obviously during atherectomy, one of the consequences is perforation. Worried about type 3. And we actually, during CSI, we had a left main perf. We had to cover it with a covered stent. And obviously when we used that covered stent, we ended up occluding the circ at that time. And we had to take a Supercross 120 and an Supercross 120 and an Osteo 20 to fenestrate that covered stent to provide TIMI 2 to 3 flow back to the circ. And then on the right hand side is an example of a LAD perf during atherectomy. So now we've started having covered stents in the room anytime we're planning any atherectomy cases, just so to decrease the timing. And then in terms of perf management, we kind of spoke about some of this stuff, but placing a covered stent, identifying the location of the perforation, and if it's in your main vessel, placing a covered stent. But if you have those distal, on the right-hand side here, distal main vessel or distal side branch, you can consider coils at that time. But if there's any questions, feel free to chime in and chat about any of these charts that I showed. I can go back.
Oh, this is perfect. And then, Michael, maybe for a reference, since a different institution, but similar practices, is it pretty similar to you? Like in your cases, do you typically have the cover stent ready when you do atherectomy, or you're more conservative approach, trying to see how things go? How do you typically handle when you do complex procedures?
Honestly, if the perforation happens right after atherectomy, it's different from like regular balloons or anything. I think covered stent would be the first thing to go at this point. And like a few tips that I've recently learned, that of course the papyrus it gets so difficult to deliver within calcium. So having guideline or guide extension ready would be very helpful in this situation, like to protect your papyrus from coming off and to help deliver it. And the other thing is, I also recently learned that papyrus, when you inflate it to like more than 14 atmospheres, the edge itself can cause more perforation of the vessel, especially if the vessel is so fragile after atherectomy. So I've learned to like deliver the papyrus at like low atmospheres, and then when you have everything ready, you can post dilate it. Any thoughts on high pressure inflation of papyrus?
Yeah, these are great points. And actually, papyrus expands better compared with the graft master because it's just a single stent versus 2 stents. Having said that, I think what you say is reasonable and depends on the sizing of the papyrus. If you are sized 1-to-1 or generous more than 1-to-1, then yeah, definitely you should be careful because, as you said, the vessel can be fragile and might have both actually the edges, but also the part of the perforation might get worse as well. But you should always post-dilate. So even if you deliver with a lower pressure, always take a high-pressure balloon, then do IVUS, make sure that you are, first of all, seal the perforation, but also the stent is well expanded. There are some people actually who actually put a drug-eluting stent inside, which is, again, off-label, but they're concerned for the risk of restenosis since papyrus and graft master are both bare metal stents, essentially, with a PTFE membrane. So having a drug-eluting stent might reduce the risk of restenosis, especially if you put multiple on them. The other tip is if you have a perforation, try not to use very long stents because depending, of course, on the size of the perforation, because it's much more deliverable if you have a shorter stent, plus then you lose a fewer branches, which might be less of an issue in, let's say, the right, but can be a bigger issue in the case that we saw before with the left main perforation. But again, excellent tips and tricks. It is important to have perforation, get the balloon up immediately. And then if you have a massive perforation like the ones you saw, especially in atherectomy, where you typically make a bigger injury of the vessel, then being very prompt with your cover stent with a ping pong technique is a good way to go.
Thank you. All right, Michael, if you're ready, you can go.
Yep.
Wonderful. Wonderful. Perfect. Again, thanks. Excellent. Thank you so much. Excellent case presented. Now, there are a couple of questions. Maybe we can go in the meantime here. There's a question about experience with the Indian balloon skin implantation. He's asking if I have experience with the Indian balloon skin implantation. Which, to be honest, I'm not so sure exactly what is the technique, but I know that people have used in the past stents where they take, they do a mini surgery, they take a vein, and then they put a vein around the stent and deploy the stent with the vein in the perforation. Again, sounds great, but I mean, to be honest, I'm not sure many of us have the skills to actually, first of all, take the vein safely, and then also deliver it and deploy it safely at the site of the perforation. So I think pretty much that's not done quite any place right now. All right, and let me see if there are any other questions from the chat. That looks like no. So, okay, perfect. So, Michael, you want to go next?
All right, awesome. Thank you. Thank you for this opportunity. And I thought I'd give like a little bit of different flavor and something that we do at Henry Ford, like, and it's always a question, which is osteocalcification. I picked like actually a cool case that we did of a severe calcified single ostium coronary tree that was treated with CSI, and I have no disclosures. And like going right to the money, our patient is a 73-year-old woman. She was diagnosed with cardiomyopathy a long time ago, and she had an ICD in place, but she apparently did not have any coronary workup at that time, which is really interesting. She presented with non-STEMI and acute decompensated heart failure, and she had an angiogram at that time that showed single ostium left main and RCA. I'll show you the images in a little bit, and both were arising from the single ostium, and both had severe calcification. So she was transferred to us at Henry Ford for high-risk PCI. And you see, these are her images. You see here severe calcification and single ostia, pretty scary looking with calcification actually. And as you already see in the images, we decided to go with an Impala CP support, and given a low EF and high risk anatomy, even without considering her hemodynamics. And she already had an ICD in place, so we did not have any concern regarding going bradycardic or anything. And the decision here was to go promptly with atherectomy of these two lesions. So we decided to go with the orbital atherectomy, and like a few tips that I want to share from what I've learned is that, especially when using orbital atherectomy for osteal calcification, we want to use a non-aggressive guide, like a guide that can be kicked out. Like in Lindsey's case, we used the JR4 because calcification was like, the JR4 is not appropriate in that case because the calcification was distal. If the calcification is like osteal and we want to tackle that, the non-aggressive guide like JR4 would be very reasonable. And if we're going to use orbital atherectomy for osteal disease, a Viper wire advance, which is a steel core wire, is much better than the less stiff Viper wire advance with flex tip, which is 9-0 wire. And then usually, the most common, and also was a big fan of that, is doing the retrograde orbital atherectomy, which is advancing the crown and then rotating and then pulling back. And the main idea was to avoid any problems or any injury to the aorta going in with the orbital crown. But also the antegrade method can be useful, especially if the calcification is so severe and cannot be crossed with the crown. It can be done with proper technique and careful technique. So this is what we did. We used an MPA guide, which is actually pretty good for an anomalous ostium coming from the right cusp. And then we did primary wiring with the Viper wire advance. And we decided to start with the left main first. And then we did orbital atherectomy into the left main. And we started with the low speed. And usually low speed could be enough, especially if you go in antegrade, and that's what we did. But we also could go back retrograde, and then we did antegrade again with high speed because we felt that the calcium did not respond with the sound and auditory feedback. And then we took an angiogram just to confirm that there is no dissection here, because we're going to pull that wire. And then we pulled the wire and we rewired into the RCA with the same Viper wire advance.
So Michael, very good question over here. So obviously here you have a bifurcation, right? And that's a critical, it's almost like, I mean, it's like not just the left main, it's worse than a left main because everything is applied through this.
Exactly.
And you're atherectomizing right next to the other vessel. So any thoughts about doing something to protect the other branch in case that things went south? Putting a guide extension. So some people sometimes here put a microcatheter over the side branch wire.
Yeah.
Some other people here put a guide extension over this to kind of try to exclude the side branch as much as possible. I don't know, any thoughts? Was that something of concern, or you thought that distance was enough that it was unlikely to have any issues there?
We actually brainstormed all the ideas. We thought about putting in a microcatheter, and of course, putting a microcatheter would be better to do it with rotational atherectomy than CSI. I'm not aware of reports of CSI with a microcatheter. I'm aware of reports with CSI with orbital, rotational atherectomy with a microcatheter, so like a fine cross. But we thought that the distance here is enough and that we're not going to lose any of the vessels. And we opted not to use it. And I actually would love to know your thoughts, because this has been controversial, using a microcatheter to protect the side branch. And there has been like a lot of discussions recently in Twitter that says that, you don't have to do that. This might be an overkill. The microcatheter could get injured. What are your thoughts on that? Have you used this technique? Do you like to use it? Lindsey, what do you think?
Yeah, so we've done a few cases in which you use a microcatheter. We use fine cross mainly into the side branch wire. The interesting thing about it is actually that we had actually in one microcatheter, we poked a hole. So we did a atherectomy on it, on the other wire, and that actually caused a hole on the microcatheter. And looking at the microscope, it was a fairly good damage. So I suspect some of the material of the microcatheter actually got embolized further down. So yeah. I must say, I'm not very excited about this. I don't do this much anymore. But what might work well is like in cases like this, if you have a little room before the takeoff of the vessel, is to get a guide extension and do atherectomy through the guide extension, with the guide extension essentially protecting the side branch, which may or may not have a wire, from the effects of the crown in this case, or a berry-fit rotational atherectomy. So that's something that can be done. And again, might be a little safer because you're not actually atherectomized next to the microcatheter, but everything is advanced through a guide extension. So this is one way to do it. Now, I would agree that in your case, you have enough distance, probably not enough disease at the ostium of that other vessel, circumflex, whatever that vessel is, right, coronary, that you're probably okay. And clearly from what you showed us, you really did not have any issues there. Is that right?
Yeah, we did not have any issues from that standpoint. But would you be able, like, let's say we wanted to use guide extension, how would it be done with osteal disease like this? I mean, it's not very common to have like.
Yeah, I mean, you just put it essentially right up to the ostium, essentially at the carina, just put it with the carina in this way, kind of protecting the other branch. Again, it's not perfect. And here in this case, you did have, it looks like fairly significant calcification. If you show us the original picture of this, it looks like you did have fairly significant calcium coming almost all the way back. So you didn't have as much space in this case, and as you may have in some other cases, yes, where there's actually a landing zone, so to speak, of the microcatheter. So here it's probably going to be less useful, but because the other vessel, the right coronary, essentially doesn't seem to have that horrible disease at the beginning, then again, and there's a good angle It looks like a close to 90-degree angle there between the RCA and the left-sided vessel. I think you're probably okay. I mean, obviously you worked out very well the way you did it. Did you do a right heart cath where the pressures, the PA pressures go up when you're doing atherectomy, or you didn't use right heart cath during this?
We didn't use right heart cath because there was no like doubt in this case that we're going to use Impel with a like single ostium. So I mean,
Sure.
We usually do it if we have any like doubt, but in this case it was pretty straightforward decision that we're going to use it. So
Perfect.
yeah. Then we rewired. We did the same thing with the RCA with the orbital atherectomies, again, low speed and high speed. And then we ended up like ballooning both, a kissing technique. And we decided actually, because we thought that there is a very short stump and they are not totally separate ostia, we decided to do like a culotte, if you call it, like standing into one vessel and just recrossing, sending the other and just ballooning. And it worked out pretty well. I mean, I don't have the IVUS images here, but it was pretty good expanded after we were done. We just culotted into this vessel with a final kissing, and this was our final result right here. And I mean, she did very well, and she actually went home like the next day. So like the small tips that I would have for osteoorbital atherectomies, we said using non-aggressive guides and to try to remain coaxial as much as possible, be able to kick out the guide and get it in back easily. MP as we used, probably very rarely used, but for anomalous vessels, it works pretty well. And GR for the right. Using a supportive wire, the wire provider advance. Starting with low speed, you do only high speed when necessary, and it can be performed antegrade. It can, with proper techniques, slow and steady and coaxial. It can be done if the lesion cannot be crossed with the crown. And then the other technique is if you're not very sure that you like broke all the calcium or anything, you can test with an NC or a cutting balloon. And if it didn't expand, you use the same wire, it's pretty strong wire. You can go again and do a atherectomy again. And finally, definitely imaging, and especially IVUS more than OCT would be very helpful in those osteo lesions. So thank you.
Yeah, thanks, Mike. That was a great case. Actually, there's a question that came about if you use rotablation 1.5, it did not cross, and then 1.25 did not cross, then what would be the next step? So any thoughts about this, Lindsey, and then Michael?
So if neither the 1.25 or the 1.5 crossed?
That's right.
You know, it's tough. I mean, I guess you can try to use a larger burr, but you know, you can consider using a CSI at that point. But you know, I think that would be very challenging.
Yeah. I mean, that I'd say it's very unusual, but it can happen. But then I'd say that everything other than the atherectomy should be optimized. Like if you're radial, switch to femoral. If you're 6 French, switch to 7 or 8 French. Use 45 long sheath. Use a very supportive guide. Use guide extension that extends very close to the lesion. Use a support. I mean, if you whatever wire you cross with, and then if everything doesn't work up to 1.25, you can use a Sapphire Pro, try to break as much as possible. You can use laser. That's another option to just try to create a pathway for this. And if laser didn't work, I mean, we always have the option of going like subintimal and try to crush it, or subintimal and cross the other side. But I guess this is very extreme.
Yeah, no, I agree. And again, there is the algorithm for balloon uncrossable lesions, right? So essentially, if that happens, that would be a balloon uncrossable lesions. And always for these lesions, the first step, actually, before you even try to do atherectomy, is to try with a small balloon. Sapphire works pretty well. Takeru balloon works pretty well. And then sometimes if it doesn't work, you can push the balloon down as far as you can. inflate at high pressure. Again, talking about a 1.0 to 1.5 balloon, not a bigger one, and do granuloplasty, which essentially is intentionally rupturing that original cap. And then after you do that, quite often you're able to advance other equipment. If this doesn't work, the next stage is to get more support. So guide extensions or the anchor techniques. Of course, if you use atherectomy, the guide extensions are the way to go. Laser is very useful, and sometimes actually the laser doesn't necessarily cross the lesion, but it can modify it enough that then subsequent things like balloons or atherectomy, burrs or crowns can actually cross. And one option we haven't discussed is if everything else fails, to potentially use the subintimal techniques in which you can advance a guide wire intentionally around, kind of subintimally around that area of heavy calcification and inflate a small balloon there, essentially crushing the calcium from the outside. Again, aggressive technique requires that you are very familiar and very comfortable with CTO techniques, but can work. Another intriguing proposition that Stefan Harp just proposed actually is to do intravascular lithotripsy if you have a bifurcation in the main vessel. And that sometimes can actually modify enough the side branch to facilitate other equipment for going through. So you do have quite a few options. In terms of microcatheters, you can also use something like the Tornus or the Turnpike Gold that are plaque modification microcatheters and might modify the lesion enough to allow subsequent equipment to go through. And also beware, if you're doing like 4, 5, 6, 7 runs of atherectomy and things don't work, be careful, because sometimes people get really mad, so to speak, and they push really hard. And that's how you get bad things like the rotablator burr may go through and then doesn't come back. Or when it comes to orbital, you push it many times, you may actually fracture something or kink the wire and fracture the wire. So when you are getting your temperature rising, when you're feeling angry, this is the time to just take a deep breath, stop, and reassess the situation and see exactly what is going on and what can be done. And usually always start with the simpler things. Again, the small balloons, the microcatheters, guide extensions first, before going to the more complex and potentially more risky techniques. I personally actually did have a case that I did like 15 runs of orbital and then eventually broke the crown, and then did the rotational, didn't work either. So sometimes just taking a deep breath and letting it go might be the way to go versus getting really, really super aggressive and potentially having heavy complications, because as you heard before from Lindsey, perforation is always a possibility, especially for highly tortuous vessels. So many tips, but sometimes being less aggressive might actually be the way to go. Another question, Mike, for you is about the orbital atherectomy for Osteo lesions. Do you do them coming back? Go in at slow rotation and then do the atherectomy back? Use the glide assist to go in and come back? Or what technique do you think, or would you use for Osteo lesions like this one?
Yeah, great question, and that's actually one of the things that I wanted to highlight in this presentation, because I would say the classical teaching, so to speak, is you advance with glide assist, and then you do a retrograde method. You just pull the crown back while it's rotating, so you can avoid injury going in the aorta with the rotator, with the crown that is rotating. But the one thing that I wanted to show from this case is that if you have everything correctly and you cannot cross with the crown with a Viper assist, you still can do integrate. You still can do integrate with proper technique. You have a non-aggressive wire. You have to be like coaxial. Use the Viper advance, it's very stiff, and then you go low speed and go forward, and it can work pretty well. And that's actually what we did in this case. We did not use Vlad retrograde here. We just used the integrate. Again, you necessarily have to do it. The retrograde is safer, and if it can advance and then you can pull back, you can do it safer. But if needed, you can move forward with the crown rotating over the Viper advance. Now, what do you think?
Yeah, perfect. No, these are great points. I think you're right. I mean, I prefer to do them coming back, but sometimes you cannot do that. And then in those cases, the key thing is to not start your atherectomy, your orbital atherectomy, way back into the aorta, because that's when you may get unconstrained rotation of the crown and potentially injure the ostium, get dissections, get bad things to happen, or even sometimes even fracture the wire. So if you're going to do this, the way to do it is make sure that your crown is engaged with the ostium of the vessel before you start spinning. And I personally prefer to go low speed for those. I mean, in general, low speed, but especially for those, just to minimize the potential excessive rotation of the orbital crown. So Osteo lesions are actually often calcified. And that's why before you put a stent, you do want to make sure they fully expand if you put a balloon or by doing IVUS. But if it's not fully expanded with balloons, or if it's so calcified you're going to do upfront atherectomy, then you want to confirm before you put a stent that actually you prepare the lesion enough. There are some cases in which we place stents in the ostium of the right, and then the stent collapses. And it's not like it wasn't expanded, it was expanded, but there is such a high recoil pressure that it kind of collapses the stent. And sometimes we even had to put peripheral stents there, bare metal peripheral stents that have a lot of radial strength, and they don't collapse as much by the high recoil force of the ostial right coronary artery. So again, osteo lesions with calcium are a problem, but again, you can get good assessment. And actually, I would say also for technique, the other tip here is you can use a stiff wire. So this is probably the only lesion subgroup right now that I'm using the old Viper wire, not the flex tip. So the Viper is a little stiffer than the flex tip, which might be useful for these osteo lesions. And the same also for the rotational atherectomy, the Rota extra support. That's the one lesion subgroup that I would be more likely to use the stiffer wire than they use the Rota floppy guide wire. Again, take your time, slow with orbital, back and forth with rotational, and make sure that it's well modified before you go in. Now, there were a couple of questions coming through. One is about IVUS. Were you able to do IVUS before doing orbital atherectomy in this case, Mike?
We did not attempt to use IVUS pre-orbital atherectomy. It was pretty clear it's severely calcified and we would need atherectomy. And I highly doubt that IVUS would have been delivered. And I mean, again, we IVUS right away after we did the CSI, but at this case, I probably don't see the value of IVUS pre-atherectomy.
Yeah, and I think you're right. I think the chance of crossing this with IVUS, start modifying that lesion is, I mean, not zero, but it's fairly close to zero. I think once you have such tight, heavily calcific lesions, it's unlikely you're going to do it. And if you actually push very hard, you may disengage the whole system and lose your wire access. So that's unfortunately not as easy to do as after you've done atherectomy. And then another question that came is about doing sequential intravascular lithotripsy, and how has anyone tried kissing intravascular lithotripsy? So I don't know, Lindsey, Michael, have you used much intravascular lithotripsy yet? I know it's a fairly new system, and there have been some financial challenges with using it, but how has been your experience with this if you've used the system so far?
Actually, IVL works pretty well. As you know, we were using the peripheral ones before, and the peripheral ones are bulky, difficult to deliver, 40 millimeters and all that. And the coronary ones, I mean, we have used it fairly good amount, and it really works pretty well. It is more deliverable, but it is still, even with the 12 millimeters, still bulky. And it's very reasonable to use in very tortuous vessels that we worried that atherectomy would cause perforation. I don't see that this would be the case in this scenario, in my case, at least right now. And I would say that it's still very tough to deliver in very severely calcified lesions. You might need to make room for it, but I highly doubt that it could have been delivered in this case, especially with basically no guide support and very osteo lesion, severe calcification. So it works pretty well, but I'm not sure the applicability in this case. So what do you think? Do you think it would have crossed?
A great question. And actually, some people are using Rota Lithotripsy, so they kind of use combined. They use atherectomy first to get you some channel to deliver the IVL balloon, because as you said, it's not the most deliverable balloon in the world. And then just to make sure it's fully expanded, then they can use, people have used intravascular lithotripsy after atherectomy. It is obviously an expensive proposition to do it. It does work for many lesions. The key there is whether you have circumferential calcium or not, I think, in my mind. If you don't have circumferential calcium, IVL might not work quite as well as if you have circumferential calcium ring, because there's kind of an area where the waves kind of get diffused and they don't hit the plaque hard. At least we've had a few cases like this where it was harder to expand. But for circular, thick calcium, you can get some nice fractures with intravascular lithotripsy, which can be very useful for expanding those lesions. There is also the high pressure balloon, the SIS balloon, SIS OPN. You may have heard it. It's not available yet in the United States, but hopefully next year it may become available. And that balloon can go up to 35, actually even higher, up to 40 or 50 atmospheres. And that might be able to crack some of those lesions as well, but it does have the same limitations as IVL, which is deliverability. It's more bulky, as you expect, than the standard balloon. So getting it to the point where you try to expand the vessel can be a challenge. The other problem here is, especially if you have a calcific nodule or very eccentric calcium, and you go very, very high at high pressure and a large balloon, that's when you may actually perforate the vessel. And we saw some pretty dramatic perforations from Lindsey's presentation earlier on. So it's something to keep in mind that how aggressive you are depends also on the vessel. And in those very calcified vessels, it might be better to go with a slightly under-expanded balloon and even accept a slightly imperfect lumen. Maybe you are not 7 millimeters square, but you are 6 millimeters square. That might be enough than trying to go very aggressive and potentially risk a complication such as perforation in those lesions.
I actually just had a quick question. Going back to the protecting the side branches in Rota, what is the largest burr? You would have to use an 8 French system, I'm assuming. What is the largest burr that you can use in the 8 French system? Is it a 1.5 or a 1.25 for protecting the side branch of the fine cross microcatheter?
You mean to deliver the better crown through the guide extension, or?
Sure. Well, when you're also protecting the side branch at the same time.
Yeah. So actually, for orbital, you can get it through a 6 French guide extension.
Okay.
For rotational, I actually have to look at my chart. I don't remember out of hand right now, but for orbital, you can get it through a 6 French guide extension. What happens sometimes is that you have a hard time if you try to load, if you have the guide extension in place, and then you are trying to advance the atherectomy device, it can hang at the collar of the guide extension. So what we've done a few times is actually preload the crown or the burr, preload it within the guide extension, and then outside the body, and then insert it as a set, as a group, and then advance them together until they come out. Of course, that assumes you can deliver the guide extension to where you want it to go. But if these lesions are proximal, which usually they are, then that's often not a big problem. And this way, you don't have the issue of the wire wrapping around the rod of the guide extension, and you don't have the issue with the crown or burr not making all the way to the tip.
Right.
Again, it's something that can be done, can be done both ways. And Nikos Kakouros had the case report of this a couple 3 years ago, and it works. It works very well. Having said that, also be careful not to perform multiple passes inside the guide extension, right? Because you might save some pieces off, which may not be the best way to do it as well. Right. So you want to start your run at the tip of the guide extension versus way back into the guide extension, potentially atherectomize inside the guide extension.
Right. Thank you.
Perfect. Any other? Do you have any other cases?
I don't know.
Okay. All right.
I actually just have one question. Now we're talking about perforations. It might be the best way to ask and discuss it. So for perforations, we know we can use a ping pong technique if I have an 8 French, if I have an 8 French system, or if we can use another guide. And this has been the classical way of doing it. So what do you think, and Lindsey, what do you think? Right now with the papyrus is more deliverable, and with the you got extensions that can be used to at least be delivered to the perforation site and like seal the perforation until we deliver the papyrus. How often do you still use a ping pong technique to deliver covered stents? Do you think it still should be like the standard for using, just challenging the standards?
So I actually have never, I've had a couple of perforations and we have never used a ping pong technique, although that is a great idea to use, but we will immediately provide balloon tamponade proximal to the site of the perforation, try to advance our guide liner as far down as we possibly can, get the papyrus, ready, and then just quickly do the exchange and deliver the covered stent. I haven't used the ping pong technique yet to deliver the covered stent.
Yeah, and I feel that this has been like the standard that we've been doing. Like when you have a perforation, you try to get the guide liner as long as possible. You try to deliver your stent as soon as possible. And I have not seen like the ping pong technique like used a lot. Maybe with like type 3 to 4 perforations when you have like spilling blood and you want to stop it and you cannot deliver the guide liner and the perforation is so far down, maybe it would be helpful. But what do you think, Dr. Brilakis? Do you still use the ping pong technique a lot?
Yeah, that's a great point. Actually, that came up on the chat as well. So here the key consideration in my mind. The number one question is, how bad is the perf? If you have like a small perf barely oozing out, then you do have more of a luxury of time to potentially take your blocking balloon out and get your cover stent in. The second is how fast you can deliver the cover stent. If it's proximal and there's not much calcium or other problems, and you are fairly confident you can deliver it very quickly, then yes, then maybe you don't necessarily need to go for the ping pong technique and deliver through the same guide. Actually, and that's actually an area where the 8 French guides are very useful. If you have an 8 French guide, you can deliver the covered stent, papyrus specifically, and a blocking balloon. So actually, you don't need to get a ping pong. You can do everything through the same 8 French guide. But if you have 6 or 7 guides, then it's much harder. That's where the ping pong comes in. But in my mind, at least for large perforations, I think the ping pong is still the way to go, because this way you minimize the bleeding into the pericardium and the risk of tamponade. What can happen, I've had a couple of times where you perforate something, looks pretty bad, but then after 10, 15, 20 minutes of balloon occlusion, you take a brief puff and actually it looks much less or almost like a dissection, not really free flow out in the pericardium. In that case, you may also have some luxury of time to just take your balloon out and then just put the cover stent. So depends on the perforation size, and also depends on how bad is the issue that you're having. The other thing, though, that I found sometimes interesting with these perforations is losing the wire. So sometimes people get a perforation, which is not the most pleasant thing, obviously, in the world, and then next thing, panic comes into the room, and next thing you know, now you've lost your wire. So what would you do next if this were to happen to you? Knock on wood.
Well, I think the first attempt is try to rewire it again and hope that you're lucky to not just go through the hole and be able to deliver it distally. But if you cannot, I'd say that's a bad situation. That's not ideal.
Yeah, no, absolutely. And I guess the solution to this is, you call the surgeons, right? There is a point in life about calling the surgeons and going for emergency surgery, and this may be one of them. If you lost your wire, you have a major perf. Maybe there's not much that you can do for that. So this is one of the things that can be done to minimize that complication. Another thing that came up as well is about reversing. Would you reverse the heparin once you have a perforation with atherectomy or otherwise?
So we partially reverse if we do have a perforation. Only, actually we just had a case the other day where we partially reversed and then ended up actually the patient did have an effusion. But I guess the thought process is too that you don't want them if you fully reverse, then you have a chance, if there is some blood in the pericardium, it becoming coagulated and it's difficult to tap later on. So we usually typically try to partially reverse in our cases.
Yes, and one other point that in Hereford, for all CTOs, and this can be up for debate, we don't preload them with P2Y12.
Yeah.
We just don't. We can load them after, but that's one thing. That's just in case a perforation happens, you don't have like an active P2Y12 on board. And we do partial reversal as well. Full reversal would be a little tough to do with the balloons and everything, right?
So here's another question that just came up about the restenosis rates. Given the high restenosis rate with covered stents, other than clinical assessment, are you following them up with any repeat angiogram or any other imaging? So curious, what do you do in Mass General and Henry Ford?
We don't have a practice in place where we re-image. If they're symptomatic, then we would take it back to the lab, but we don't have a system in place that if we place a covered stent that we bring them back for a relook or any non-invasive testing to see if there's any under residual ischemia or anything. We kind of just deploy and then, do DAPT as we normally would. And then if they have symptoms, we would take them back for a relook if needed.
Yep, same. No system.
Yeah, no, I completely agree. I actually want to share one thing with you. Mike, do you mind just stopping the share for a second?
Mm-hmm.
And then there is one case that I personally have found very, very instructive. And I want to show the image to you. It's actually a published case. And just curious to get your thoughts on this. Can you see my screen okay?
Mm-hmm.
Yes.
So you can see this is a heavily calcified lesion, so similar to the lesions you were saying, it's an LAD. The vessel is not huge, but it is a decent size, at least 2.5, maybe 3.0. And you see they're trying to do rotablation. The bear is trying to go but doesn't go. Now, what do you think about the right panel?
So it looks like that the bird jumped, and then it looks like you successfully got through the lesion. You would be concerned potentially maybe that there's a perforation. You could have broken through the lesion, or if you did slip through the lesion, I would be concerned that potentially you'll have a difficult time getting back, although it looks like you're able to get back. But that quick jump distally does make me a little nervous for a potential perforation.
Yeah.
All right. So, Mike, what do you think?
Yeah, the jump is following the wire. That makes me more like.
And now I see that it's next to the wire, so completely off the wire. So perf.
Oh.
So this is something you don't want to see in your life, but but if you see that, you know that this is not going to be pretty, obviously. And I guess there are many things here, as you said, right? I mean, atherectomy, rotational. So orbital, you just go nice and slow and advance 1 millimeter a second, right? And that's perfectly fine. But when you have rotational, you want to do this pecking motion. You hit a little bit, you come back, you go back and forth. You really don't want to push it very hard, especially if it's stuck in the same place, for many reasons. One is that then you have the risk of causing embolization because you're stopping the blood flow. The other thing is you may get the bear stuck. The third one is that here it looks like there was a bend, and by keep on doing that, I think probably what happened is the wire kinked, and then the bear is going out. So, I mean, that's a traumatic moment. I must say, when I saw this, I'm still getting traumatized every time I see this fluoro. But it's very instructive. I mean, it tells you what not to do when you are doing, again, rotational atherectomy to avoid having these issues. Now, what would you do next after this happens?
Don't lose the wire. Number one. That would be. But although I'm not sure if the wire would be king, you exchange it and then balloon right away, right? Wow.
Yeah. It's quite a
Wow.
quickly to get your covered stent, or if you don't have the covered stent in the room, get any balloon you've used prior, provide tamponade until you can get the covered stent in the room, and then just deliver the covered stent as quickly as you can.
Yeah, absolutely. And I think this is the case where, are you going to do the cover stent here? So you ask the question? I guess you don't have to ask the question, right?
You also call the surgeon just in case.
Absolutely. I mean, this is the one, actually, you call the surgeons right away. Looks like they have a body wire now. And then would you use a ping pong technique here, as we discussed before, or how would you put the cover stent here?
I mean, yeah, based on the size of perforation, I think ping pong is very reasonable to do it. Especially, I think that cover stent will have some tough time going in there. But again, to my previous discussion, if you can just get a guideliner, shove it in right away up to that area, seal that with a guideliner, then deliver the covered stent, unsheath it. Would that be also reasonable? Maybe, I don't know.
But to do that, what happens to the balloon? How are you going to guideline with the balloon up? Unless you get the balloon down, but that means you have to get the balloon down, take it out, put the guide extension in, right? So that means, at least a minute.
Or deliver it over the balloon, right? You can deliver it over the same balloon. Like
no, but if it's not loaded, you have to deflate
you have
it, right?
to take it out and exactly. You lose a minute. Yes. You lose a minute there and a minute there. Yes.
Yeah, so that's going to be exactly. So that's the concern there. You're going to lose too much time.
And the other point with this case, I mean, with the burr going out like this, I mean, your rota wire is probably kinked, right? So you probably will not be able to use it to deliver all these devices, correct?
Yeah, absolutely, you could. But I guess here, the bottom line for me is that you have a massive perf. Every second that you have the perf uncovered, you are going to lose a lot of blood in the pericardium. Mm-hmm. And this is the one you don't take the chance. This is the one you take your time, you get a second access, you put an 8 French 45 long sheath, go up with another EBU 8 French guide, have the wire right there, ready to go. You have the cover stent preloaded, ready to go. You quickly deflate, get the wire down, reinflate, give yourself a few seconds to catch up your breath, and then deflate the balloon, get the delivery, get the cover stent down, and then remove the other stuff. Don't remove the other balloon until you have the cover stent there, because you may have a hard time delivering, as you said, in this calcium and bends, and then it can be a lot of time. But a good idea to have the surgeons know about this. If it doesn't work, you may have to go that route and fairly quickly. And then I think Stefan Hart makes a great point that sometimes you can still not cross the lesion because you still have a lot of calcium, right? More proximal, even though you perf the vessel, you may still have a lot of calcium more proximal. Some people might even coil that, but coiling the middle AD is probably not the best way to go there. Wonderful.
Did you have to rescue after you placed that cover stent? Did you cover any of the diags that you had to try to rescue, or?
Actually, this is a published case. Actually, it wasn't my case. It's a published case that I wasn't part of. But I mean, for me at this point, I will be very happy to get out of there without diagonals if I can get my LAD okay and the perforation happen. I mean, sealed out. So I know obviously you want to keep the diagonals, but in this situation, I think the more priority is to just bail out. And I wouldn't feel, to be honest, I wouldn't be very bad if the patient went for bypass. I mean, seal it there, suture it, make sure there's good hemostasis, and graft LAD is probably not a bad way to go as well. Mm-hmm. So you have different options, and that's why technique is critical, right? You want to get this done as a way to go. Another way that Stefan is saying, which is another intriguing way, is to get a balloon out to the pericardium and kind of stop blocking it there in the meantime. But yes, this is one that massive perf that you want to deal with as fast as you can. All right. Well, I guess we did talk a lot about calcium. And again, calcium can be something that can be challenging. There can be a lot of things that can go wrong when you do calcified lesions, including perforation. You didn't show it, but you can also lose equipment. It's not infrequent to lose stents. Actually, I've lost a couple of stents in the last month. You prepare the calcified lesion, but I guess we did not do a good enough job. and then during attempts to deliver a stent, the stent comes out of the balloon. That's another potential complication for having calcium. And then you can have other things like the stent then goes in, and then you have a big waste into the stent. I know we didn't talk about this much, but Lindsey, any thoughts? What would you do if, let's say, you put the stent in, and then now you deployed it, you thought you were expanded, but now there's a big waste in that stent, and you're in the middle AD. And of course, now you don't feel very comfortable atherectomizing again. What would be your next action there?
Well, you can try laser to see if that yields the stent or any modifies the plaque any more, that you can provide some post-dilatation after that. You wouldn't really want to do it in a fresh stent, but if you need to get further expansion, you could try IVL at that point. So you hope that doesn't occur, but you can try other options in the algorithm if that does occur.
Absolutely, Michael. Any other thoughts?
Yeah, because we're talking about fresh stent, it's a little tough. But if we have fresh stent and we have that, I mean, I think the go-to right now is to use IVL. Though with the fresh stent, you lose the polymer, you lose the drugs, but it's better than having stent thrombosis if the stent doesn't expand. So you can, that's what you have to do. And we had cases where none of that worked. And we had actually a recent case that we tried laser, tried IVL from like an old stent, and nothing worked. And to the point we used peripheral CSI, and it didn't work. And we had to go to like the extreme of subinterval techniques. So it can be pretty bad. It can be pretty bad, and you have to be ready to go to the maximum.
Exactly. And also the other way there is to put if you don't have IVL or IVL doesn't deliver, the other option is to do the time-tested laser with contrast. So you get the laser there, you do some runs while simultaneously injecting contrast. That creates microbubbles. Actually, I think the effect is fairly similar to the IVL effect, microbubble cavitation formation, the acoustico-mechanical effect, and you might be able to modify the stent enough to then expand it with a subsequent balloon at a non-compliant balloon at high pressure. And also, we've had some cases in which using a plaque modification balloon like angiosculpt or chocolate or cutting balloon actually has been useful in some of those cases as well. So there are options, but the key for all this is to have the algorithm kind of fresh in your mind so that you can act quickly in case that this is needed. All right. So again, thanks again very much, Lindsey. Thanks again very much, Michael. Thank you all for attending the webinar. I think we're a little late, but we covered a lot of ground today with excellent cases and excellent discussion. So thank you both very much for excellent cases. Good luck with the rest of the fellowship and then following on. And look forward to seeing you in person, although AHA was canceled today, so I guess it doesn't look very promising for the near future at least. So.
Hopefully not. Thank you so much.
Thank you so much, Dr. Brilakis.
Thank you so much. You have a wonderful night. Thanks everyone for participating. I appreciate it.